Hi, everyone. So let's talk about asthma. It's one of the two basically diseases under the umbrella of the obstructive pulmonary diseases. This lecture is just going to be about asthma. I'm going to record another lecture on COPD, okay? So, what is asthma? Well, basically, asthma is this chronic disease of the lung that literally it's reversible, but it obstructs the airway and it's related to literally a lot of triggers. For example, it could be foods, it could be dust, it could be like sprays. A lot of people might get the smoke or irritants of a spray, aerosol spray. Even medications such as aspirin, NSAIDs could cause it, as well as respiratory infections like maybe like allergic rhinitis or sinusitis. It could be related to even wine. So in other words, there's a lot of triggers that can cause asthma. Now, keep in mind, and I bolded and sort of capitalized all the letters. This is reversible. Someone can get better from asthma. Um, when we compare it to COPD in a different lecture, you're going to see that COPD is non-reversible. um, you have different classifications of it. It could be as severe as causing death. And as a matter of fact, a lot of people die each year from it, and it causes a lot of hospitalization. Men before puberty are at most risk, and women after puberty. And it's most common seen in African Americans and Puerto Ricans. And honestly, to tell you the truth, I don't say that because I'm Puerto Rican. It's actually documented, and it has to do with the air that is very saturated and polluted, and also it's a tropical island. All right, so a little bit of the patho, I like to always review pathophysiology for you. So we have this allergens, triggers that literally cause the immune system to be activated, and then inflammatory process happens. It causes vasodilation, then your bronchi constrict, that's the bronchospasm. You get this congestion, um, where literally you have edema, mucus, and impaired gas exchange because the pipes, the airways, are obstructed. Okay. So it sort of look like this. A normal airway kind of open, but when you get the asthma, um, they're really tight. And if you recall back to bronchitis, it's sort of it's similar how the pipes and the airways look, okay? However, these are more for triggers. Over there, it could be bacterial. In bronchitis, it could be a bacterial infection or viral. This could just simply be anything, really, even medications. All right, so how does it look? Well, especially in asthma, we have clients that are going to have this distinct wheezing. Um, and again, that's due to the fact that, the pipe where we're inhaling and exhaling is so constricted that the lumen is small, and therefore, think about a straw when you are blowing through a straw. um if it's really small, it might make this kind of like wheeze sound. And you're going to have a lot of restlessness and anxiety. The clients, if they're not able to breathe, imagine, they're struggling to breathe, they're struggling to get air. They get very anxious, very restlessness. And as a matter of fact, it's one of those first symptoms, because they're like trying to, okay, let me breathe, and that gets them really nervous. You're going to have this chest tightness where it feels almost like they take a breath, but it's not sufficient, and they have to sort of force it in, like really effort, with a lot of effort, just sort of like, okay, I'm taking that breath, and still they feel like that's not enough. They'll have coughing, shortness of breath, maybe some nasal flaring or accessory muscles being used. In worst case scenario, they could have a weak pulse and diaphoretic and really respiratory failure where they turned blue. Um, Asthma can progress very quickly into a life-threatening situation. And they have these two terms that the book mentions that I would like to discuss a little further. So, um, silence chest means that we have to monitor and assess and carefully, evaluate the fact that maybe someone was wheezing and suddenly they're not wheezing anymore, or their wheezing decreases significantly. And, you might think, oh, well, they're getting better, but in fact, they're actually getting worse, okay? Because the silent chest, what it means is that it actually could potentially be that no air is moving through, and therefore you don't hear those wheezes anymore. So that could lead to potentially complete obstruction, and then respiratory failure is coming next. So if someone is, normally wheezing and suddenly out of nowhere stops not wheezing, you might want to think like, are they getting worse? Okay. And then the next is status asthmaticus. And this is a medical emergency. Not that the silent chest is not, but status asthmaticus is a medical emergency. It literally means that the patient is getting so severe where the asthma is getting worse and worse for the past 24 hours, and it's not responding to any of the treatments like bronchodilators. When this happens, you really need to seek medical help. And, in a way, they could present with status asthmaticus first and then leads to silent chest, so you could see that as well. Asthma is sort of diagnosed with the history of the patient, the signs and symptoms, but, ideally you want to do a spirometry. A spirometry literally kind of tells the physician the narrowing of these airways and the bronchial tubes narrowing. Because what the patient does is that they're going to be tested with how much air can they exhale after a big deep inhalation, like after they take a big deep breath, how much air can they get out and how quickly they can exhale this air. And they test the client before and after a bronchodilator. So, in order to get a spirometry done, you have to stop any sort of treatment like bronchodilators in this case before the exam, because we want to know your normal vital capacity of your lung and how much can you exhale. Then they measure that, and then they give you a treatment, and then they measure it again. All right. If it gets better, then we know we have asthma. We have constriction of these or narrowing of these bronchial tubes. Now, I will be honest with you, asthma is usually underdiagnosed. Like a lot of people might have asthma and not even realize that they have it. And they just think it's, oh, I'm just shortness of breath, or it might be I'm fatigue, or maybe I'm obese, and they actually have asthma. Another test that they could do is something called peak flow meter. And not only is it used for diagnosing, but also as a maintenance to see how well and how control you are with your asthma. And so peak flow meter just measures, the how much air is coming out of your lungs. Um, and so it works as a monitoring of the severity of the asthma because if let's say you're feeling kind of weird, you're having some of the symptoms, and then you do the peak flow meter and you're like, whoa, my amount of air being exhaled is decreased significantly, well, your asthma is not under control. Along that, they could do allergy testing because a lot of allergens and antigens trigger asthma. They could do chest x-ray just to see how your lungs are doing and if there's any um, structural changes, and then oximetry. So what do we do with these clients? Well, primarily we want to go ahead and literally maintain, not prevent any complications, especially those life-threatening ones, and then achieve this control of the asthma. You don't want someone having to take, you know, two puffs every 4 hours every day. That means your asthma is not under control. So excuse me, you sort of want to, make sure that maybe the asthma is triggered just in the winter or springtime because of pollen, or only when I get sick, or only if I take that medication and not a routine daily thing. We want to educate our clients to avoid any triggers. We want to educate the family as well and the client on things that they can do in order to help their asthma. So, positioning is very important because it allows for lung expansion, especially, if they are kind of restless and sort of anxious. um, Reassurance, like just like, hey, okay, breathe with me. We got this. Like, I'm here with you. You can do it. Breathe with me. One, two, three. And then we show them, or we teach them these techniques, such as the pursed lip breathing, which is kind of putting your lips like a duck, like you're gonna kiss someone, like burping your lips, and then you're exhaling air. So like, you know, there's a description of that in your book in page 540. But literally, you just kind of close your lips like they look like little duck lips, like you're about to kiss someone, and you just slowly exhale air. That takes out the carbon dioxide. It's expelling air out. It's helping you remove this air from your lung. Not the air, but the carbon dioxide. You can provide oxygen if the airway is open, but you can give these patients all the oxygen you want, and if they're tight because their airways are constricted, then no air is going to reach them. Then we need to teach them how to use an inhaler and a nebulizer. They need to have their inhaler, their rescue inhaler, at all times with them. And there's some teaching for that as well in your book. I'm going to go over it here in a little bit. Then we also talk about the action plans. Think about the action plan as a guide that tells the patient, whoa, you're getting to this danger zone. It's time to call the physician or go to a nearest emergency room. So green means like you're good to go, like you're good, you're controlled, keep going, like keep going with your current treatment. Yellow means like, we're in the warning zone. Like you're not doing best, but you're not doing worse, super bad yet. Maybe keep going with your therapy that you normally, do, but then add this or that. And then the red zone means like, okay, we're in really danger, stop zone. Like you really have to put everything on board, and then go get some medical help. We should also tell them they have to avoid um, NSAID products, aspirin, all these selected blockers, non-selective blockers, they're called, such as propranolol. It's a cardiac medication because it literally inhibits bronchodilation. So if someone is on aspirin, someone is on this beta blockers, especially propranolol, which is a non-selective medication, your bronchos are not going to dilate. In fact, they'll constrict more. So we don't want that for these clients. They want to hydrate very well. They want to rest. You want to spare out their activity so they're not tired. You want to treat every infection very promptly. As a matter of fact, there's a very high link between sinusitis and bronchitis, sinusitis, and asthma. So a lot of patients that develop sinusitis or bronchitis will sort of lead to asthma or triggers their asthma, I better say. And then there's, the medication treatment, the pharmacological treatment that we can speak about as well. And I will go over it here shortly. So here's a picture of the action plan. And if you can tell, it makes you measure their peak flow level, and then kind of danger, caution, and then you're good to go. And then how much of the medicine you're going to take, maybe the frequency will increase in the caution area. And then on the red, hey, if this is not getting better, you really need to go seek the medical help. So explaining this action plan to a client and educating them about it, it's very important. Okay, moving on to, let me switch the pages here, the pharmacological therapy. So, one of the things that I want you guys to do when you're studying these medications is for asthma, is which meds are my rescue medication that if I am having an acute right now asthma attack, I'm gonna need. I need these medications. They're going to rescue me. They're going to help me now. And which of these medications are sort of maintenance and long-term control medications? Meaning I'm not going to use them if I'm having a acute asthma, I can't breathe, panic, full-blown attack right now. These long terms are more for controlling the symptoms. So under the umbrella of bronchodilators, which dilate, open up your pipes, your airways, you have your short-acting beta-2 adrenergic agonists, or we abbreviate them as SABAs, SABA, S-A-B-A, and they're your albuterol. So albuterol, levoalbuterol, or Sonopex, these are your rescue inhalers. They kind of come in this little L-shape little tool, and then anybody can carry them in their purse, and they could give themselves a puff or two if they're having an asthma attack. Now, here's the thing with albuterol. It works very fast. Within minutes, if you inhale it correctly and you hold it as you're supposed to, you will feel it within minutes. Their effectiveness lasts between 3 to 5 hours or so. So every for your rest, your sorry, whatchamacall, the prescription of a client will say use every 2 to 4 hours or every 4 hours as needed. Um, and then with them, you want to actually teach your client that after they do 1 or 2 puffs of albuterol, they're gonna feel these things that are adverse effects. Um, And these are totally normal. They're part of the medication. So they'll have tachycardia, they'll have tremors, like they start shaking, they feel like little ants are inside them, because it stimulates the central nervous system. They will elevate the blood pressure. They might have a little bit of dry mouth, as well. But again, this is just sort of expected in a client. We know it's going to happen. We might not right away, let's say, call a physician if you just gave an albuterol treatment to a client and they have a 105 heart rate. Well, it's 105. It's expected. We know the heart rate will increase. With that, with mentioning that it can elevate the blood pressure and the heart rate, we want to be cautious because, I mentioned in the um, upper respiratory lecture that we can use decongestions whenever we have sort of lots of mucus and are stuffed up. Well, one of those decongestions is Sudafed. And so Sudafed is used for asthma people as well as Mucinex. It's kind of part of the treatment, but keep in mind that Sudafed can cause, elevated blood pressure. It's not indicated really with people that have heart issues or blood pressure issues. And then if you combine it with a bronchodilator, then we got bigger problems. On the other spectrum of the long-term control medications, you got the long-acting B2 adrenergic agonists, and they end in terol. So no more the albuterol, they just have terol. And so these are long-acting B2 adrenergics. They're effective for 12 hours, and you do not give these when they're having a acute immediate attack. This is more for just controlled or, secondary in combinations with maybe a steroid, um, usually. Okay, then we have your anticholinergics. Anticholinergics are considered sort of rescue medications. They are used as a second alternative to SABAs, to albuterol. And most of the time, you are going to see in the hospital a combination between an albuterol bronchodilator and ipratropium anticholinergic. We call them duonebs. And so duonebs, DUONEB. And so it's a combination medication. It has an anticholinergic and it has a bronchodilator. Anticholinergics work a little different. They work by um, preventing the muscles to be tight and contracting, and therefore it kind of helps them to relax and dilate. So we want that. We don't want them contracting and basically being narrow. We want them relaxed and open. So that's why anticholinergics are also sort of like a second alternative to SABAs, and they are considered a rescue medication. They act fairly quickly, and it can cause this dry mouth, palpitations as well, and headaches. Then on anti-inflammatories, we have inhaled corticosteroids. So now we have steroids but being inhaled. Now, with the inhaled corticosteroids, you're sort of can say that they're like long-term controlled, um, not necessarily I'm having like a acute immediate attack right now. I need to open my airway. I'm going to do an inhaled corticosteroid. Um, They are used in, when patients are admitted with asthma attacks, but not initially. It's sort of once they are stable, then we want to bring the inflammation down, and therefore they'll give them an inhaled corticosteroid. And so most of the times they also get initially IV steroids. Here's the thing, what you have to watch out with steroids, whether they're inhaled or um, taken by mouth. So if they're inhaled, you want to do education on rinsing their mouth, because steroids lower their immune system. And so it can kind of give the patients thrush or this yeast infection, also causes cough and hoarseness. A lot of the times they are, advised to be used with a spacer to kind of prevent that thrush and kind of stuff in the mouth. And then again, you can see results in weeks, in order for the immune system and the inflammation to go down. So that's why it is not considered a rescue medication, because it can take weeks to see results. If you give a steroid IV or um, intravenous or oral, then we're looking at more systemic symptoms. So, some of the things to consider is that steroids can cause your glucose to go up. It can also cause you to be restless and have a little bit of insomnia, in addition to being hungry. So they gain a little bit of weight, they're hungry, they're restless, have insomnia, and causes your glucose level to go up. And that's important, especially if you have a diabetic patient. Okay, you want to consider that. You want to cover them, you want to monitor their glucose level. Then you have this other category here, methylxanthines. And one of the most common one under that category is theophylline. And theophylline, they end in thylene. Um, I don't necessarily particularly see this medication that often anymore in the hospital. Very, very rare. But NCLEX still tests over it, and it's still in your book, so we kind of cover it. It is not your first line of treatment. And the reason why we don't see it so much in the hospital anymore, it's because this drug is kind of problematic. It causes a lot of toxicity. And so because of that, it interacts with a lot of other medications, and the window for toxicity is sort of like, kind of troublemaker. I call them troublemaker drugs. Uh, Excuse me if you're thinking like, why is she saying trouble? Yeah, I just call them troublemakers. Um, but anyways, yeah, the toxicity of the drug can cause like seizures and nausea, vomiting, tachycardia, and so yeah, that's not really good for the clients. And then you have this medication that we've talked before in rhinitis. Um, we talked about leukotriene receptor blockers, the Montelukast Singulair. So Singulair comes into play in asthma because you can prophylactically prevent a asthma attack if you stay on the therapy. Um, so it's used as a maintenance therapy and prophylactically to not get an asthma attack. Now you got to take it every day. And so, and it sort of works by making sure that you don't have this allergic reaction that can lead, it blocks its receptors that can lead to asthma. Again, not used for acute attacks, and it should be taken 1 hour before meals or 2 hours before meals. So that's something else um, to sort of teach your client about it. Okay, let's see. How do we use an inhaler? So a lot of what we do is teaching our clients. If you haven't noticed yet, you know, we need to teach our clients everything, and we're constantly teaching them. And so that's part of what a nurse does. So learning or teaching the client how to do an inhaler, a meter wand versus the dry powder one, it's very important. So let me go over it. So when you have a meter wand, doses are preloaded in there. And so every time you press and a puff comes out, that meter will start decreasing on in the doses. And of course, you don't want to let it run out. You want to, when it's running out, you look at how many you have left, and you get another refill for it. So that's why it's called meter dose. You have to shake it very well. Shake, shake, shake prior to using it. You want to angle it at 90 degree with the client sitting upright. You remove the cap that has at the end. The client will breathe out, just kind of like let all the air go out. Then they press, it delivers the puff, and then the client breathes the medication slowly all the way, as deep as they can. Breathe in, and they hold their breath for about 10 seconds. So I tell my clients, okay, count one in your mind, 2, 3, 4. Once those 10 seconds pass, or as hopefully you can wait the 10 seconds, then you slowly let your breath out, and you should wait 1 minute between puffs. Now, in contrary with the dry powder, you have to load the medication. So here we don't shake. We just sort of load with your finger. There's if you see the picture here, and you might be able to find some YouTube videos on how to work these. Um, but it kind of looks like a sliding on the top that you just slide, and it loads the powder. You don't shake it. You seal your mouth around the mouthpiece, and then you breathe in very quickly, like like you're sucking it out of it, right, really quickly. Then you hold your breath for 10 seconds. And then you just let out the air after that. All this patient teaching is in your book, 651 and 652. I would really strongly suggest that you look at those and you know what to teach your clients in regards to how to use one of these. Now let's talk about the difference between a nebulizer and a spacer. So a nebulizer is mainly this machine that converts the solution into like a mist, like a steam mist, so that patients can just inhale it um, like they're breathing normally in and out. Um, Now it could be delivered via this apparatus mouthpiece that just goes in your mouth, or it can be in a face mask. It depends what your client is comfortable. However, sometimes, like for kids, you might do smaller mask and versus adults, you have your larger mask. You want to sit upright. You want to breathe just deep and slowly and kind of hold for 2 to 3 seconds so that way you can um, sort of let that mist reach your lung completely. And then once you finish with your treatment, you want to wash out the mouthpiece or the face mask with soap and water and allow it to dry. Now the spacer, it's what's on the bottom here, and it almost looks like a little tube that you can connect your meter inhaler. And really, the goal of the spacer is for people that might not understand the holding of the breath, or they might have a coordination issue where they cannot like hold, press, hold, and then let the air out. Especially we use these for children or elders. They might not cognitive be there to understand what they need to do. Imagine trying to explain a 5-year-old, okay, breathe out, hold your breath. And, so once the medication is um, pressed into the chamber or the spacer, then it's held in there, and then the individual can just breathe normally in and out. In that way, the medication is delivered directly into their lungs. Let's recap a little bit. Excuse me. Let's recap a little bit about asthma. So it is a constrictive, chronic but reversible disease. We're going to teach the clients all their symptoms, which one of the main symptoms is this, wheezing, mucus, cough, chest tightness. They might end up in asthmatic. Status asthmaticus or silent chest. You want to diagnose it with spirometry. You want to teach them how to do the flow meter so that way they know which area they are in the action plan. You want to teach them how to do and monitor their symptoms and kind of know when to seek help. You want to teach them how to effective breathing techniques such as pursed lip, pursed lip breathing, where they exhale that carbon dioxide, positioning, avoiding any triggers, hydrating, resting, eating well, spacing their activities. You want to educate them about the pharmacological therapy. I'm just flipping through here. How to use the inhaler versus a dry powder versus a nebulizer. Involve the family and educate the family as well. Okay, and that's pretty much, about asthma in the overall spectrum and overview. I hope it was helpful. And as always, my references are from the book, and your images are from Google or the book. And I hope this was helpful, and I'll see you in the next lecture.